Hello and welcome to another episode of Rings a Bell podcast. I'm your host, Kim Callio, and I don't remember a whole lot from pharmacy school. So I invite a guest on to quiz me and then roast me about what I don't remember on a clinical topic. In this episode, I get quizzed about anxiety by Rami Safi, a pharmacist and pharmacy owner who also has a master's in counseling psychology. How's that for a resume? I'm super grateful to have had Rami on here quizzing me, roasting me, informing me about all things anxiety, and I think that you will enjoy the episode too. So, without further ado, here's the show. So, Rami, welcome to the show and tell us a little bit about your journey of getting to where you've gotten to.
Thank you, Kimberly, and thanks for all the audience. I appreciate this opportunity. Yeah, so I actually am a pharmacist since 1998. I came to Canada 18 years ago, and I started my practice where you are in BC. So that was for a couple of years, and then I moved to Hamilton, Ontario. That was in 2010, and I've been here since then. So I decided around COVID time to do exactly actually during COVID time, the first year of COVID in 2021. I decided to enroll in a master's of counseling psychology. Many reasons. One of them was actually a personal thing toward psychology that I always liked. Also, I saw the impact of emotions on workers, on people, on patients, on myself, and I really wanted to explore that field. So I actually, what brought it also is like, I realized after many years that people who come to the pharmacy are not happy. And then this actually got amplified more and more with COVID. People were scared, angry, mad, frustrated because all these emotions showed up differently. And all of it actually is a cover for mainly a fear. So people express it differently. So the surface emotion looks like different, but the depth of it was mainly fear. And that made me, and even that applies to employees, because I was at that time I was responsible for almost 50 to 60 employees, and I was seeing this daily, and I saw that if I knew how to manage my emotions and understanding and processing, I would really understand why this staff member doesn't want to show up, why this staff member is trying to prove something. And of course, I can be more accommodating in my approach toward my workers, and how it makes a difference when you try to lead by example, when you manage people's, especially when it comes to their lives, because you're seeing this every day. You're seeing, instead of seeing a patient or a caregiver that is worried about their health and they're worried about their life, you're seeing this in COVID every day with 50 of your staff members and their families and the patients. So it was an intense, it's like special forces pharmacy operation, where you have to really like get into understanding more of that. And I really liked to explore it in the proper way. Beside that, I have some personal thing about being myself an immigrant 18 years ago, and I saw how I went through and I'm still going through these emotional, roller coasters sometimes. So all these made me think, how can I, pursue more on it? So I decided to study counseling psychology.
Okay, so sort of started from an organizational psychology perspective.
100%.
Cool. And you're able to balance doing a counseling practice with also doing pharmacy practice
Yeah,
right now.
so 85% of my weekly work is in pharmacy still, and 10 to 15% of work with some clients on psychotherapy. So it's like two hats, but I'm mingling some of the skills that I learned in psychotherapy and in speaking to clients into pharmacy practice. For example, what is motivational interviewing, and how you can actually manage a patient with chronic pain, and what's the psychology behind people not taking their meds or not
Oh, yeah.
compliant. So there's lots of overlapping areas where, so I'm trying, I don't know if I'm the only, I know that there's pharmacists who did psychotherapy for sure. I know a couple, but I don't know if they practice in pharmacy or if they try to see it from that perspective. But I know that I'm one of the people who really wanted to create that kind of like
Mhm.
connection. So
And you say you're wearing 2 hats, but I understand that you're also an owner of a pharmacy?
yes, so
So you have
yeah,
3 hats.
so well, if you want to talk about hats, I have 500 hats. So I keep myself busy. I manage and own a pharmacy myself, with a couple of pharmacist partner too. But my core work is always technical. I love the
Mm,
so they are more into like uh, some of the work that I can do, but I am more into the patient support, like direct contact and
mhm.
frontline, because that's something I really have passion for and I like to do a lot. So
Yeah, that gives you the warm fuzzies, and
yeah,
then your other partners can take care of the books,
yeah,
hopefully.
that's exactly what it is.
Yeah,
Yeah,
perfect.
yeah, it's a puzzle when you partner with for business. Like you have to have people who are better than you in some aspects, and you might be better than them in some aspect. That will make it much better for everybody. So,
Absolutely. Okay, well, can't think of a better person to quiz me on anxiety,
oh,
which I have a lot of lived experience as a person with anxiety,
who doesn't?
but my but my knowledge around that topic is as, comprehensively, that knowledge is as
Yeah.
old as at least 8 years since I graduated. So there's what I learned then, which I'm sure has changed, and then there's what I have managed to remember.
No, I mean, first of all, just to uh, for your point about anxiety, I mean, I don't think anybody didn't or hasn't or will not go through anxiety. There's nothing like this. It's a myth. Nobody. The difference is some people might actually reflect it and manifest it, and you can see it in front of you. Some people have an ability to emotionally regulate it, and and sometimes they don't really. Some people have this naturally in them, like the way they emotionally regulate it. And I've met some people like this in my life, and I was like, how you do it, but we all need some level of anxiety, because otherwise we can't really do anything. If you're not anxious a bit about driving the proper way, you will have more accidents. If you're not anxious a
Hmm,
bit about studying a bit more, you will not really pass the exam. If you're not, the problem becomes when anxiety make you dysfunctional, either emotionally or work wise or study wise or relationship wise. This is the
right.
biggest challenge, and we all. I mean, I am speaking for myself. Definitely, there was times when I might have been dysfunctional because of being too anxious, and
Mhm.
one of the traits that anxiety has, or one of the traits that people who were more susceptible to get anxious is people who are perfectionists. So if somebody is perfectionist, they are exactly more prone to become anxious.
Yeah, shout out to anyone who worked with me during
Yeah,
COVID.
yeah. So that tells you something. If you and you can easily Google and find tools to see if you're really perfectionist or not. And there's few questions you can ask, and then you ask, you talk about it, and you'll find out that what I think part of my anxiety is just I'm trying to be perfect, and of course
Mhm.
that actually realizing that is half of the problem, because you will just say, okay, nobody is perfect. I have to be realistic.
Yeah. Well, and this podcast is an exercise in anti-perfectionism for me.
Yeah.
Because,
Nice.
I was finding myself at a point in my working journey where I felt like, uh, do I know enough about it's tough being a pharmacist in community because you're a generalist and things are moving so fast,
Yeah.
and yet you don't have as much time as maybe you'd like to look into things or feel super comfortable on all of the parts of community practice. And so I kind of felt myself spiraling in, oh, do I know enough to go back into the dispensary? And then, well, something comes up and then, you lose confidence over time. So for me, this podcast is an exercise in I'm not going to know everything about every topic, but at least I can have someone come on and quiz me and I can remember the basics of all the topics.
Yeah.
And then hopefully that helps other pharmacists who are on the ground who maybe don't have the time to host and record and all that stuff.
And I really loved how you put it, because that's when I got connected with you, when I saw it on LinkedIn, about it was the iron deficiency, I think, and I loved how you made CE more of a fun, and normalize actually the fact that we all actually, we shouldn't know everything like on the spot. We need to revise ourselves and
Mhm.
think and revisit stuff, but it's totally fine. It's okay. It's fine. It's
Yeah. Yeah,
so I
absolutely.
appreciate that a lot. It's really fantastic way. I loved it. So
Okay, let's get into the quiz.
yeah, so let me start with the first question. And which neurotransmitter systems are actually most implicated in anxiety disorders?
Um, I remember GABA being involved. So
Fantastic.
the
That's great.
GABAergic. And then, I mean, the classics,
Hmm.
serotonin,
Yeah.
dopamine,
Okay.
norepinephrine.
Yeah.
I don't know the mechanics of how
Yeah.
exactly they're
Yeah.
involved,
Yeah.
but
No, that's fantastic answer. So you did very well. So actually, but in order for us to, the three main ones are GABA, as you said, serotonin, absolutely, and your norepinephrine, and then to a lesser extent is dopamine, glutamide, and CRF, something called CRF. Or corticotropin, sorry, releasing factor, corticotropin
okay.
releasing factor. So, uh, and that's as of today, because you never
Right.
know. And today is April 9th, so we really don't know if like tomorrow something come up and they have this new whatever, like
Right, right.
neurotransmitter, because as we all know, brain is so sophisticated,
Mhm.
and neurotransmitter science is so big that we really, like, everybody's like, there's something, it's all overlapping, and together. So that's fantastic answer. That's great, Kim. Can
Okay.
believe
So more GABA, serotonin, norepinephrine,
yes.
less on the dopamine
Yeah.
side.
Yeah.
Um,
And glutamate and the corticotropin releasing factors.
CRF. Okay, got
Yeah.
it.
Okay. Now, what is the primary neurobiological difference between generalized anxiety disorder and a panic attack?
The difference between generalized anxiety disorder and a panic attack.
Yes.
I mean, a panic attack is more acute and there's a lot
Yeah.
more, I would say, like maybe more aggressive activation of sympathetic
Yeah.
nervous system.
Yeah.
So you're getting into that like heart rate, breathing rate, all that kind of stuff.
Yes.
Don't know the neurological components that
Yeah.
lead to that, but
Yeah. That's actually a great answer. So let me put it in the way you actually talked about it. So we as pharmacists, part of what we sometimes counsel is, especially when people are starting on some medications like SSRI, we would say, and this is part of the thing, is like, you might find some anxiety. Did you have any panic attack before? And some people don't really know what panic attack till they know what panic attack, because, and we as pharmacists should be aware about that. So my I've always mm, talked about panic attack, and then I realized what a panic attack when I had one. Uh,
Mm.
and it's really bad. like, yeah, it's horrible. It's like, and I get it. Like, I understand when somebody says I have a panic attack. Yeah. Now, when you think of it, panic attack is actually a protective system that we have, in a way.
Mm.
So it's a manifestation for the flight and fight. So let's assume, and that's why when I speak to a patient in my pharmacy or a client at the psychotherapy, and they mention that they have panic attacks or they have symptoms that are symptomatic. So we all know what's the flight and fight. And then when you are just assume that you're walking in the street, and then out of nowhere you have this, coyote, like, coming and just attacking you, or a dog. What you have two options. It's either you just flight or you just fight. Both options will be actually dealt with in our physiological system in the same way. So what will happen if we're hungry? We're just, our stomach will shut off. If we really want to urinate, no, it's not gonna happen. We get into extreme stressed status where our muscles will actually become very constrained, and then our heartbeat will go up, and that's all because one of the things that we are wired about is to keep our blood actually to our bodies. So if we get injured,
Mm.
we don't bleed that much. And even if you look at, I know it's graphic, but sometimes if something come up and, like, somebody is actually in a fight and they get stabbed, the blood will not just flow right away. Sometimes it takes time,
Mm.
especially if they were in rage, you know, because they're already in the mood of panic attack, and their body is keeping the blood, and that they don't start like the bleed right away. So our bodies are actually wired to protect our lives, and when we see that, we actually get into a mode of panic attack. Now, the difference in the panic attack is that simply, I always say, that dog that's attacking you is actually in here. It's hidden somewhere, and that thought triggers your panic attack, even if you don't know where it came from. Because people also,
Mm.
because it just happens. Like sometimes people would say, I just have, like, my palpitation started to, my breathing is like fast. I start feeling like I'm gonna die. I like, and I start, like, having, some people would sweat a lot. Some people would, like, have all these symptoms. It's simply your mind is telling you you are under threat.
Right.
So,
Okay.
and your anxiety is getting into you. So your anxiety is triggering your anxiety is convincing your brain that you are under threat. You have to, and that's why your panic attack comes up. So
Okay. Whether or not there's actually an external threat.
yes, exactly. It doesn't have, because that's what triggers, of course, the post traumatic. Because you have a trauma. Like some people, they had an accident 10 years ago, but out of a sudden they started having panic attacks. And when you speak to
Mm.
them, you realize that for whatever reason, something triggered that memory again and again. And I really advise people to look into Gabor Mate work. If you just go into
Mhm.
YouTube, who is a Canadian physician, he's one of the masters in trauma, in the trauma actually ward, and he has a lot to talk about trauma and its impact. And there's also a great book called the Myth of Normal by him,
The
actually.
myth of normal.
Yeah, of
Okay.
normal. So uh, the generalized anxiety disorder is more of a chronic hyper. So it's more actually physiologically, it's more located in the amygdala of the brain. So it is
Oh.
developmental in a term, and it's more of a chronic condition than the panic attack in a way.
And the amygdala of the brain is doing what?
So it is actually the fear center,
Okay.
which means it's controlling our, or it's actually where we get the fear. And part of it, when it's not really developed that much, in some cases, that's people who actually have like less of fear to do things. So if you do like,
Like my
yeah,
toddler.
yeah. So, well, the kids, yeah, the kids are a great example because they're still developing their amygdala. They're not like, and that's why it's actually an important thing to understand that the 18 years old boy
Mm,
actually is not the same guy who when he becomes 30, because amygdala, they still take risks and they still like the fear side is a bit off with them. That tells you why, why we have more accidents, unfortunately more accidents for kids below 25. And I think it's also related to some people who have some forms of ADHD where actually they're higher risk, and that makes them higher risk in terms of like their safety in a way. So
okay.
mhm.
So it sounds like the generalized anxiety disorder is more of an amygdala problem where your fear center sense your fear center thinks
Yes,
that it's sort of hyper aware of fear
all the time, and it's chronic.
versus
It's
and
chronic.
it's chronic.
Yeah.
Yeah.
The other one is it's a surge that happens to uh, uh, the non-adrenergic burst. So it means it just when it happens, your body will react right away without that, not without amygdala part, but it's not a chronic situation. It's more of an
Right.
acute burst. Yeah,
An acute burst and they
yeah,
can kind of feed into each other, I would imagine.
absolutely.
Okay.
So, what are the first line treatments for generalized anxiety disorder according to the current guidelines?
SSRIs, SNRIs?
Yes.
Mm.
And guess what? CBT. So
Oh, yeah.
CBT, yeah, CBT actually, which is cognitive behavior therapy, and people who are interested, there's actually lots of courses on CBT that you can take and just understand it. The most famous is the guy who actually created it, which is and he's still alive. I think he's in his 90s. Big Institute in the US, and there's something called big inventory for depression and big inventory for anxiety. And actually it's CBT is sometimes CBT might work actually by itself. You don't really need
Mm,
an SSRI or SRIs in some cases. So it's evidence based. So big argument that they had done it over like many thousands of people and it worked, and that's why it became actually very instrumental in many of the health institution. And it's actually about reframing and reconstruction of thoughts, and which makes
mhm.
total sense. So it works for some people, and for some people it doesn't. It just depends.
Right.
So yes, you're right. SSRI, SNRI, and or CBT.
And or CBT.
Yeah.
Well, that's kind of a nice story about the is it BECK? The
Yes.
Beck?
Yeah.
Yeah, yeah,
The
yeah.
big
Okay.
big institute. Yeah. If you just
Yeah.
Google it, there's only one big institute. Yeah.
Well, it's kind of inspiring to hear that a person who was peddling, you know, inner workings of your mind,
Yeah.
helping you out with anxiety,
Yeah.
not peddling drugs, came up
Yes.
with all of these scales that we use
Yes.
as compared to, we're studying this drug and we need to get it to market. So then we need a study to prove it works. So now we have these questionnaires.
Yeah.
It's kind of nice that he was just
Uh,
kind of like, your brain knows what to do.
so just to explain for the audience, in psychotherapy and psychology, we call these modalities. So CBT, uh, there's something called ACT or acceptance and commitment therapy. There's like IFS, internal family systems. All these are called modalities. And if you're, for example, pursuing psychotherapy, uh, usually people would start with a light version of modality like CBT or ACT. Sometimes it works for them, sometimes it doesn't. Then people will start going into deeper modalities that are actually really deep. And these deeper modalities especially with traumas. It supports a way in order for you. It's not about forgetting your trauma. You'll never forget your trauma, but it actually makes it easier for you to emotionally respond to it. Which is, by the way, if you told me this 20 years ago, I'd say, "What are you talking about?" But honestly, I see how it works, and it's
Mhm.
insane. Sometimes it's just like people would say, I actually, went through lots and really like bad stuff. And when they did
Mhm.
specific modality, it worked very well for them. And that tells you the extreme connection between, as we said, neurotransmitters, physiology, and actually medication, as well as, other things. So
Mhm. Are we talking like EMDR
yes,
in
exactly.
terms of
One of
the
them
deep?
one of them is called EMDR. Yes. One EMDR is
Okay.
really heavy stuff. And when people are licensed in EMDR, they're like really licensed. There's like also, and there's actually even deeper one. There's one called
Mm,
brain spotting, I think, something like that. It's
okay.
also, yeah, it's also, so there is like different modalities, and people sometimes it works for them much better than the lighter version of it. But yeah,
Interesting. Okay. It's so fascinating to hear all of these things about psychology without
yeah.
having to read a psychology textbook
Yeah, yeah,
because,
yeah, yeah.
no,
Yeah,
thank
no,
you.
no, it's actually interesting because it affects all our life. I mean, it's us, it's
Mhm.
our kids, it's our parents, it's our family, it's our community. So,
Yeah.
then number 4, name 2 rapid nervous system regulation techniques pharmacists can teach patients at the counter.
Um, so one I use all the time is the box breathing thing.
Oh, excellent. Can you explain it?
Yeah.
Because that's actually one of the answers.
Okay, yeah, so, and I think I heard this on CBC radio one time, and
Mhm.
I started
Yeah,
doing it actually during COVID times because I needed it. So, yeah, you breathe in for a count of I don't know if the count matters, but I do 4 seconds. So you breathe in for 4 seconds, 1, 2, 3, 4. Then you hold your breath for 4
yeah.
seconds, 1, 2, 3, 4. So you're going
Mhm.
across the box. Then you're going down the box with the out breath,
Mhm.
1, 2, 3, 4. And then you're holding again, 1, 2, 3, 4.
Yeah, absolutely. And you're contradicting what your panic or is doing for you by doing that.
Mhm.
So that's one technique. And there's also grounding techniques, different ones. One is called 5 4 3 2 1. So spot 5 things that you can see,
Right,
4 things you can hear, 3 things you can touch, 2 things you can taste, 1 thing you can smell, or 2 things you can smell and 1 thing you can taste. And the idea behind this is like when you're really at your your anxiety is getting up there, and you're really like getting worried, and you start focusing on these things, it will reduce, and it will give you that time frame that you need in order to get actually less anxious, and it does
right.
work. Yeah, so grounding techniques, the breathing is one of them, and the 5 4 3 2 1 3 2 so 1. So if these can be part of your counseling at the pharmacy station.
Mhm.
You can simply
Absolutely.
tell, yeah, I mean, especially if you find out that do you get panic attacks, what kind of, yeah, what kind of things you
Mhm.
can do.
I know the box so the box breathing is working by getting you to slow down your breathing. You're holding your breath so you're not hyperventilating.
Yes.
And then the 5, 4, 3, 2, 1, is that sort of the interplay between if you've gone into fight or flight, your frontal lobe is kind of not
Yeah.
online. So you got to
Yes.
get it back online
Yeah.
to counteract
Yes,
the other
exactly.
stuff.
So you're
Okay.
actually putting down that actually rage into a different approach.
Got
When
it.
they said, oh, the trick like count till 10,
Yeah.
it's like in
Yeah.
a way similar to it, because yeah, it's the worst moments are when you're at the top of your anxiety, and
Absolutely.
it just takes few seconds. And I also want to say something. We always tend to speak, that's actually came to me now. We always tend to speak that if the patient is in front of me and I want to advise them, use it yourself. because
Right.
we know as pharmacists that we get into situations where we feel there's aggravation is coming, like a patient is frustrated that they start blaming you for something, and or the doctor is calling, and they're like, why did you fax this? And you're trying
Right.
to mingle, and then you become yourself angry, and then this is when actually you might do something or say something that you will be actually liable and accountable for.
Right.
And it's very important that I I I know how, and we all know, especially if you're watching this like as a pharmacist or as a healthcare worker, that the amount of pressure that we get into sometimes is so big
Mhm.
that we forget that we are human beings, and we really need to practice some self-compassion and practice some kind of techniques where we have to cool down. because
Absolutely.
because anything we do, it might actually cause harm to the patient. We still have the authority in the patient, in that arena we still have the authority, so we will be perceived as being authoritarian, or
Mhm.
and that's why it's very dangerous for us to get into that. So try to practice this yourself as a pharmacist, or as a technician or as an assistant, because it's very important that we keep our calm as much as we can. So
Yeah, absolutely. That the point about the power dynamic is so key, especially when we're talking about marginalized populations. Now you're in a healthcare situation where this person with the advanced degree is talking to you, and you already might feel like you're being talked down to, but
yes,
now the person is angry.
yep, yep,
And
absolutely,
yeah. And I think it could be quite powerful for a pharmacist, whether or not you're talking to a patient with anxiety, to model that behavior in front of them and just say, "Hey,
yes,
like, actually, you know what? I'm feeling myself getting a little bit worked up. I'm gonna take a couple
yes,
deep breaths. Like, feel free to join me, but like, here I go." Kind of
yeah,
like what I do with my toddler, right?
yeah, absolutely. It's actually funny in a way that you mentioned the toddler trick. I have also toddler, but why? Because our anger is actually, sometimes it's like we're like small kids that we lost our emotional regulation,
Yeah,
and
absolutely.
we react in that way. It's like your toddler is telling you that there is a need. They have a
Mhm.
need, emotional need, and their way to express it is anger.
Right.
That applies to older people. It's not only toddlers. The difference is the toddler, is small, like, we understand it. But when we speak to our patients, we have our bias that, oh, these are mature people, they shouldn't act like this. And I'm not saying that people should like accept like humiliation or something like that. But just look at these patients and just say their kid is coming out now and they're
Mhm.
not able to regulate their emotions, and I really want to help them out by at least listening a bit and just not responding right away.
And not escalating at least,
Exactly.
right? Yeah.
Absolutely. And I know it's not easy. And by the way, whoever's talking to you now, which is me now, I definitely had a big share of like me being like, why are you speaking to me like this? It's like,
Right.
but with time and the more I understand how our emotions get, makes me more like, okay, yeah, you know what? Listen, don't
Mhm.
don't try to be defensive, just listen. It will actually reduce the amount of really bad stuff that can happen.
Yeah. Yeah.
Okay, why, and that's actually something I love to talk about also. Why is St. John wort considered risky in patient being treated for anxiety?
Um I would assume that if you're being treated for anxiety and you take St. John's wort, it could work because it works very similar to an antidepressant. It could put you into like a mania
Yeah.
state.
Yes. So what happened is it induces actually a couple of enzymes, which will enhance, which will lower the level of the SSRIs,
Okay.
and actually it causes, and even oral contraceptives, by the way, and anticoagulants, and that's why it can actually cause serotonin syndrome.
Okay, sorry. I'm going to need you to back up on that. So the St. John's wort is going to
Induce
induce.
enzymes, so CYB3A4 and CYB2C19 of drugs, basically SSRIs, contraceptives, and anticoagulant, and it can actually cause serotonin syndrome for the SSRI piece.
Okay. So you've
So
got
that,
serotonin coming up from the St. John's wort
yes,
plus SSRI serotonin, but then at the same time, it's also going to affect how good the SSRI is
yeah,
working.
yeah, yeah, absolutely.
Okay. Got it.
In what situations benzodiazepines are considered appropriate in anxiety management?
Panic attacks?
Oh yeah, well that's actually one of them, which is short term.
Right.
Yeah, and uh, sometimes if you're starting, and we see this practice a lot, if somebody is starting on SSRI, for example, their anxiety might flare up more, and that's when we actually, part of my counseling on SSRI is like, if you feel that your anxiety is getting worse, which might happen, uh, don't give up right away on it. Just make sure you contact the doctor or us, and they might give you some benzodiazepine to reduce it a bit,
Okay.
to reduce that anxiety for just a short time, for the upper like 3 or 4 weeks to come, or 5 weeks.
So this is as you're waiting for the SSRI to kick in. And
Yes.
is this if you're treating depression, it can
Uh,
increase anxiety, and also
yes.
if you're treating anxiety, it can
Yeah.
increase anxiety.
OCD. If you're treating OCD, for
Okay.
example, Zoloft is recommended, or sertraline is recommended for OCD, and OCD people are already anxious, and they already get into that, and then just imagine you're giving them something and it just flares their anxiety up. And
Right.
so yeah, so people would, some doctor, like in many, now I don't see it as much, but I still see people coming in a week or two. Some people just quit on it in the first 2 weeks because they can't tolerate it.
Okay. So you're using a benzodiazepine in anxiety if it's
Yes.
panic attack and
Yeah.
it's very specific, you're using it PRN, but then you're also using it potentially to bridge those initial exacerbations when
And
you
don't,
start SSRIs.
absolutely, and we also want to elaborate on the fact that benzodiazepines are also something that we have to reconsider for deprescribing or reducing it,
Mhm.
especially for people with, like, who gets over 60, because it's increasing the risk of falls. It's enhancing other cognitive issues, like it's reducing cognitive abilities and impairment,
Mhm.
and the danger of like having it with any other, like something like sleep medication, or, and of course, as we know, the older we get, the problems become worse because we become more sensitive to the medications. So,
Mhm. Yeah, so are you doing much work in deprescribing yourself?
fantastic question. Yes, actually, you will be shocked if you look only at NSAIDs in your pharmacy. You will find a lot of NSAIDs prescribed,
Mhm.
and people are on it for years. And if they reduce the dose for 50%, they might not even feel any difference. And
That's great,
then
yeah.
then I use it, my, like, I did it for a couple of patients, and both of them are off NSAIDs now totally, because
Fabulous.
I did it gradually, and I find out, like, they find out that it's not really doing anything. you
Right.
know
Right.
well, I said, well, it's actually doing bad to your kidneys and blood pressure. So yeah.
Exactly. Okay, fabulous. Well, one of the warriors out there getting people off drugs. It's not common, but it's becoming more common. So that is good. Did you know that benzo clearance is also affected by obesity? I did not know until today. Let me give you some more details on the pharmacokinetic considerations in the elderly, and then I'll tell you about where the obesity piece fits in. The elderly experience benzodiazepines differently in two ways. The first thing is that the elderly brain is more susceptible to the actions of benzos. So the same molecule of a benzo in an elderly brain is going to have a bigger effect than that in a younger brain. The second reason is that elderly people are slower to clear the benzos. The reason we all go too quickly is, of course, our liver and kidney dysfunction and the good old drug interactions. The part we often forget, though, is that elimination half-life for benzodiazepines is also driven by fat mass. I know you love a little math moment, so recall the equation for elimination half-life. On the bottom, you have the obvious one, rate of clearance. On the top is the part we all forget, the volume of distribution. Throwback Thursday over here. Do you remember what the volume of distribution is? Basically, if you have a low volume of distribution, the drug stays in the plasma and is readily excreted. If you have a high volume of distribution, it means that the drug gets distributed throughout the body more, so it's not available in the plasma to be excreted. Generally, you have a high volume of distribution if you have a lipophilic drug, since it can easily cross membranes and get out of the plasma and off to other parts of the body. And benzos, being that they act within the CNS, are highly lipophilic. Some more than others, but you get the point. And then, of course, the molecule's lipophilicity is a constant, but the amount of fat on a person's body will also change that number. And when you age, you get lower lean mass and higher body fat, which means that your volume of distribution goes up. Volume of distribution up, elimination half-life up. So, in essence, being elderly and being prescribed a lipophilic drug is a double whammy. It makes your bottom number smaller and your top number higher. Interestingly, this same volume of distribution issue leads to a longer elimination half-life in obese people as well. There was a study done where they gave diazepam to obese participants and non-obese participants, and then measured the volume of distribution and the elimination half-life. The volume of distribution was 228 liters in obese folk compared to 70 liters in normal weight participants. And this corresponded to an elimination half-life of 82 hours for the obese participants and 32 hours in normal weight individuals. So this is going to lead to both an efficacy issue and a safety issue. That higher volume of distribution is going to lead to a slower onset of action, meaning you might not hit peak effect when you need it most. And then, of course, the obvious safety issue of slower elimination. I'll wrap up this section by mentioning that there are benzodiazepines that are preferable in the elderly. Obviously, we want to avoid any unnecessary script, but if you have to use a benzo, you want to use one of the lots, quote unquote, lorazepam, oxazepam, or temazepam. They have no active metabolites, they're cleared by conjugation, so there's no CYP drug interactions to worry about, and they have short half-lives, between 5 and 25 hours. This gives you the best chance of not having that drug build up in the body and cause excess sedation, cognitive impairment, falls, etc. And that's all for now. Back to the show.
Okay, so another question. What is the mechanism of action of buspirone? I have, just to let you know, it's one of those like atypical kind of like antidepressants, of course.
Yeah. I feel like it's kind of like Tylenol in that
only.
there's so many mechanisms.
Yeah.
Yeah, I want to say it has like some like it does something with serotonin, but it's not like SSRIs are increasing the amount of serotonin in the synapse. But buspirone is somehow getting in there and activating serotonin.
You know what? You're really great. You know what you're talking about. Partial agonist to the kind of the receptors of serotonin, and it's actually a mild dopamine antagonist. It's non-sedating, which is one of the things, and it's non-addictive. Okay, and it takes up to 4 weeks also to kick in.
Okay.
So
I was always sort of under the impression that buspirone took longer than an SSRI to kick
no,
in.
it's actually up to 4 weeks, 2 to 4 weeks. So yeah.
So they're about the same.
Yeah. It works in
Okay.
the 5-HT, so 5-HT1A. Okay, now one more question, and I think this one is easy. Which drugs have in the psychiatry ward a narrow therapeutic window?
Which drugs in the
Psychiatry? Yeah, psychology or psychiatry, like, have a narrow therapeutic window.
Antipsychotics?
Well, lithium is actually the most famous.
Lithium?
So lithium, in order for you to make sure the patient is getting the right dose, you have to do a blood test all the time. And as what's the most famous indication for lithium?
Bipolar.
Yes, absolutely. And then nobody knows why, because it has been in the market for like whatever 80 years or something, and it's still working. It's very cheap. Some people use a small dose for, actually, I saw it off label one time as a mood stabilizer, which was weird. I've never seen it before. I saw it a couple of times. But the main indication is actually bipolar. And lithium has a very narrow therapeutic index. So people need to always have it between like two different, like, levels. Uh, if it goes a bit up, it becomes toxic. A bit low, it doesn't really work for the bipolar. And usually one of the major drawbacks of lithium is kidney effect. It has a toxic effect on the nephrology of the kidney. So that's why one of the best tips to give people on lithium is try to drink lots of water. 2 to 3 liters of water a day. Try as much as you can, because it keeps your kidney working better.
And I remember there being an interaction with NSAIDs
Yes.
and lithium.
Yeah, and it doesn't actually, it causes, that's why it's always good to keep the same approach to fluids. And it's like dealing with, in a way, thyroxine. When you take it, you have to take it the same way, but
Right.
avoid NSAIDs. But also drink lots of water, mainly water, because
Okay.
it protects the kidney, especially people who get stable in it. Because bipolar is a very tough disease when it's diagnosed, and people when they are stabilized, it's fantastic, especially on lithium. But at one point in the future, their kidneys will actually start declining. So one of the protective ways is like, it makes them anyway thirsty, but in general, people sometimes really don't drink enough water with lithium. So
Okay.
that's important. The other one is clozapine,
Right.
which has a very, like, as we all know, it's usually, in, at least what I know, in Ontario, it's kind of centralized in the approach of, doing the test for it and making sure, because it's used for extremely resistant cases, as you see it, like one of the antipsychotics. So
Right. And that's kind of the only, they've had to bring it back because it's so effective for
yeah,
those cases that are resistant, but they have very strict monitoring of it.
absolutely. Okay, so what is the serious drug interaction that pharmacists must screen when patients are taking SSRI?
Serotonin syndrome.
Yeah, and that actually happens with mouse, which is actually, I don't see it anymore. Linozolid, triptans, St. John wort, dextro, lithium. Sometimes, yeah, it does. But
Narcotics?
yes, absolutely, you're right. And even tramadol. Yeah, so all these actually are susceptible for the serotonin syndrome.
And a super common combination to see is your SSRI plus some sort of narcotic for pain,
Yeah,
because
yeah.
that they tend to go together.
So fantastic point. You have chronic pain, which will actually cause depression,
Mm-hmm.
which will cause insomnia, and that's a cycle, vicious cycle, where the patient is stuck there. So advice, if any of these patients uh, have the ability to get into psychotherapy, because yes, it help. I mean, it's not gonna just, the chronic pain will not vanish. That's, people with chronic pain knows that, and we know that. But some of the techniques used will support, your actually journey in that. The other thing is, there's something called CBTI, which is CBT
Mm-hmm.
for insomnia, and there's like other modalities that actually help with these things. So looking at it and trying to see how you can support your patient to get more care and to improve their quality of life, because it's just so these are all together. You will see a SSRI with a pain med and sleeping aid and a benzodiazepine.
Yeah,
Yeah,
absolutely.
I mean it's just a combo, unfortunately, and
Mhm.
there's lots of opportunities for many people to see, like even some psychoeducation can support,
Mhm.
actually can really help and support patients so well that you'll be shocked. Like in many occasions, for example, I'm going to give an example about substance use.
Sure.
So what do you think? There's different models that speak about substance use in the medical field. Okay, so one of the models is the moral model. What does it mean? It means if you really believe in a moral model that reflect on substance use, you're basically saying that people who are in substance are morally flawed. So if I am a healthcare worker and I have that belief, and we all know ourselves more than anybody else, I
Mhm.
should not, that's my tip, I should not work with substance use people, because I'll be judgmental without even being judgmental. And my level of care will not be as sincere as it should be.
Right.
Now, there's a model called biopsychosocial model, BBS. So there is a biological factor, which means there's a genetic tendency, absolutely. There's a psychological factor. In many situations, these people might have a huge challenge psychologically that it has never been, a trauma, a major event in their childhood uh, that
Mhm.
actually made them vulnerable, and then they cope to become like substance use people, like
And
that.
that kind of feeds into the biological part too, right? Those adverse
Absolutely,
childhood events
absolutely,
are
absolutely.
actually yeah.
And so there's B, and then social. And the social side is if you are, for example, from a visible minority, or from a vulnerable social, like poverty, for example, is part.
Right.
You don't have to be, different color in order to be like vulnerable. But if you sit in these three, and you put it in one person, the ability, and you have these three not as big as in other people, this person has more susceptibility, or more actually prevalence for substance use or behavioral addiction, because we tend to speak about substance and we forget about behavior, because
Right.
because I want to talk about, let's be realistic, even us as pharmacists or healthcare professional, we still have some people that they might be smoking, or they might be drinking alcohol, and in their stressful day they tend to have more of their cigarettes or more of their, wow. And
Mhm.
that's actually a coping mechanism. And I'm not saying it's good, but I'm just saying it's a negative coping mechanism. It's something that will add to, and that's when people get into the habit of doing things in order to feel better. And that's exactly what happened with somebody who gets into cocaine or heroin. That's exactly the same. It's just
Mhm.
like the difference is maybe the social factor. And remember that many of the substance use disorder people are non-privileged in a way, and they don't have even the social skills to ask for what they want. So that's why something you need to actually realize, so that you can really deal with these people, is like, are you looking at it from a biopsychosocial point or from a moral point? It makes a huge difference how you see it.
Absolutely, and it's, it's similar to the way we were talking earlier about, how dare you talk to me like that?
Yeah,
You have to
yeah,
kinda see the
yeah,
kid in
yeah,
them.
Absolutely. We have to understand that we are human beings. We have biases. We have stories that we heard about substance. We have
Mm-hmm.
stories. Uh, Let me tell you another. Like again, we talked about behavioral addiction. Let's assume that all of the people who are actually on now watching us later or now, if you grab your phone and check your screen time
Mm-hmm.
and check your screen time when you have a very bad day,
The doom scrolling.
that's actually a behavior that is coping behavior because you want to avoid talking to people. You want just to
Mm-hmm.
make yourself like, busy with something else that doesn't relate to because you don't want to face it or whatever. It's related to something. I'm not saying
Yeah.
that, I'm not saying it in a bad way, but I do it, you do it, everybody does it.
It's an addiction and it's affecting your neurobiology.
Absolutely. These things are just diseases. Like some of these things they will never be away in a way, but you need to cope. You need to be able to cope with them. You need to train people how to cope with them. And that applies to people with mental health. Unfortunately, many cases of substance use might not be resolved or have rehabilitation, but many also others are actually getting the chance to do that. And I'm not preaching and lecturing. I'm just saying at least be that person in the process where actually you feel and you empathize with the way they have this struggle, and just be kind to them in a way where they really feel safe when they come to your place.
Mm-hmm. Yeah.
So
At least don't add to the trauma.
absolutely. So I think that's all what I have today, Kimberly. And for what we have on anxiety, I'm sure there's a
Phew.
lot more. And I have to tell you, Kimberly, that you passed actually with distinction. So you didn't
Hooray.
actually, you answered all of them, and I'm actually very impressed with this. So thank you.
Well, it's helpful that I have anxiety myself, so I've been around the block.
Yeah, you definitely get the distinction on this. So I leave this for Kim. And thanks again, Kimberly, for the time. And thanks for those who actually took the time to watch it.
Absolutely. Well, I'm so glad that you came on and quizzed me. You made the questions approachable. You certainly have the knowledge, so I would love to have you back for some more episodes. In the meantime, how can people find you if they have questions or if they want to visit your pharmacy? Tell us where you are, where you're at. Maybe don't give your home address, but other things.
So I'm actually in downtown Hamilton. My pharmacy is in downtown Hamilton. Uh, my pharmacy name is Wellness Wave Pharmacy. And I'm also easy to find on LinkedIn. You can actually
Mm-hmm.
find it easy. I'm usually very active on LinkedIn. And yeah, please reach out and connect. And if you're in the neighborhood, just jump in. I'll show you my space. It's I love the space. It's I'm biased about it. I love it, and it's I do a lot of things in this small space, so I'm happy with it. And I'm willing for any kind of questions, and just just ask.
Wonderful. Well, this has been great. I'll let you go for now and we'll chat later about future episodes. That's it for this episode of Rings a Bell podcast. Thank you for listening. As always, you can go to the description below and find all the links to all the things, such as clinical notes and references from this episode, as well as episodes past. You can also sign up for the email list, follow me on socials, email me, etc. Thanks again for listening, and buddy, that's all, folks.